Current prohibitive laws and overzealous enforcement of opioid prescribing are unfair to both patients and their doctors. Legitimate pain patients are being denied medication because of an inaccurate assumption that prescription opioids are a gateway drug to heroin or fentanyl. Doctors can be subject to criminal prosecution merely for prescribing opioids to alleviate patient suffering. In this podcast, I will look at the issue of opioid prescribing from a patient's viewpoint, taking into account the physician's perspective as well.
Welcome to Doctor and Patient Rights Watch. I am Dr. Stefanfranzen, Professor of Physical and Biophysical Chemistry at North Carolina State University. I became involved as a patient advocate because of my experience helping a patient named Patient Z navigate the healthcare system. Based on this experience, I've opened this channel to answer some of the many questions that have arisen. For example, how did a disciplined and compliant but very ill patient end up being abandoned by a palliative care company? Why is the Drug Enforcement Administration, the DEA, arresting and imprisoning pain physicians? Who is promoting a policy to limit the supply and dosage of prescription opioid drugs for people suffering from painful diseases, as well as wounds and nerve damage from serious accidents? I would like to initiate this podcast to find answers to these questions and many others. I will discuss topics relevant to the scientific, legal, and political climate that has affected many pain patients. I hope to interview doctors and patients, but also public health officials if they are willing to answer a few substantive questions. The personal experience of a patient called Patient Z serves as one reference point. That individual experience is a kind of case history. I believe that the attitude and perseverance of Patient Z are common to many pain patients. I hope to put a human face on the issue of pain management from both the doctor's and patient's perspective. Use of the name Patient Z follows a tradition in medical reporting to protect the privacy of individuals. On this channel, I will always respect the privacy of patients and physicians or anyone else who wishes to remain anonymous. While protecting the anonymity of the patient, I wrote the book Z's Odyssey to advocate for patients' rights. Like many people who suffer the pain of incurable diseases, Patient Z would like his experience to be known. But he does not want the stigma that is attached to so many people who have spoken out regarding the efficacy and benefits of opioid medications. The private medical need for pain management has become a public concern because opioid medications are abused by some patients. On this podcast, we will shine a light on the misinformation that conflates that abuse with the larger substance abuse problem in our society. Patient Z has told me that he understands that guardrails are necessary, such as appropriate prescription drug monitoring programs that prevent doctor shopping, drug screening, and psychiatric evaluation. All of these programs are needed to ensure that opioids are being used for the purpose intended. With such measures in place, what is the reason for withholding relief from people whose diseases cause intractable pain, or even chronic pain? While I will focus on intractable pain, this channel is dedicated to all those with chronic pain whose pain is real. I hope to address these issues and to discuss the newest trends in medication, trends in other countries, and to hear what the medical community thinks. In my view, we must also advocate for the rights of physicians. Many physicians are reticent to speak up on the topic of opioids. They are justifiably concerned that they will be branded as opioid advocates. This channel is not opioid advocacy. It is intended to reestablish the doctor-patient relationship and to encourage policies that let doctors decide what is best, without fear of prosecution. With this focus on the whole relationship, the channel is named Doctor and Patient Rights Watch. I wrote Z's Odyssey to provide information to others about medical care. While I am critical of the healthcare system and sometimes I will point out poor care without naming any names, I have met many excellent and caring doctors since I began to accompany Patient Z on his odyssey to find medical care. My friend Patient Z was stricken by a serious autoimmune disease. It has grown progressively worse over the past 15 years. In the early phase, his condition deteriorated during several years, and he described to me his treatment by the medical system. The first doctor he saw told him he was imagining the back pain he reported. What would that doctor say today if he saw Patient Z's fused spine and loss of cartilage in all major joints of his body? Even before he needed help just to get to the doctor's office, I began to accompany him on his medical appointments. Since I had heard his descriptions of his treatment, I wanted to see for myself. That experience led me to read medical blogs and patient websites, as well as the medical literature. There were many failings along the Odyssey that can hopefully be teaching moments for others. It should not have taken 7 years for Patient Z to obtain a diagnosis. Patient Z should have received modern anti-inflammatory treatments years before his actual diagnosis. But none of the rheumatologists Z visited would prescribe any of these medications. First, the doctors in his area refused because they said that they did not know his diagnosis. Sometime later, he was provided with a diagnosis of osteoarthritis that was so clearly incorrect that even his primary care physician rejected it. Then, by chance, Patient Z was invited to the National Institutes of Health in Bethesda, Maryland, for evaluation as part of a study. The National Institutes of Health is also known as the NIH. I have explained the circumstances of the visit and how Patient Z found help by reading and contacting doctors with questions. When Patient Z received the invitation, I went with Z to help him through his visit, but also because I was curious to see the hospital environment at the Nerve Center of American Medicine. After 2 days of testing and consultation, Patient Z received a diagnosis of ankylosing spondylitis. The head of the rheumatology division told Z his diagnosis in such a somber way that one might have thought that it was a cancer diagnosis. As I have witnessed in the years since then, ankylosing spondylitis is more unpleasant and painful than many cancers. When he returned from the NIH, Patient Z found little had changed despite the diagnosis he'd received from the NIH. The doctors in our area who had made the original diagnosis, the incorrect one, did not want to admit that ankylosing spondylitis was the correct diagnosis. Patient Z did not have precisely the textbook symptoms, but there are many cases where lymphedema, enthesitis, and large joint damage have been seen in ankylosing spondylitis. To be clear, Patient Z did not confront the doctors about their mistake. He merely brought a 4-page document with a diagnosis from the director of the Division of Rheumatological Diseases at the NIH. Patient Z was not interested in blaming anyone, but in getting the right treatment. Instead, the rheumatologists did not recognize the diagnosis as correct for at least 1 year after his return from the NIH. By this time, Patient Z had seen all the major rheumatology clinics in our area. When a young rheumatologist moved to the area and was recommended by one of Patient Z's doctors, he finally changed rheumatologists again. This was the 5th time. Ankylosing spondylitis is a debilitating disease, but there are variants that are even worse than the textbook disease. Patient Z's disease is clearly an aggressive form. Patient Z's x-rays reveal that he must be in severe pain. He has lost almost every disc in his back. They ruptured and disintegrated before his vertebrae began to fuse. Every major joint has been destroyed by the disease. One of his hips is so severely damaged that it is essentially like walking on a broken hip. Surgeons will not operate because he is a high-risk patient. The extreme delays in treatment permitted swelling from lymphedema in his legs to cause the skin to break open and form sores. Although he has had 2 life-threatening infections, for the most part with good hygiene, he's lived with those wounds for a decade. Recently, physicians have begun to seriously try skin grafts to treat the wounds, although I was there when patient Z asked many years ago, and they denied the request. The process of obtaining skin grafts took many years longer than it should have. No one seemed to prioritize the wounds until his health was so endangered that he lived in constant threat of hospitalization. He was also pronounced such a risk that none of the needed operations could be done, and he needs many. 2 new hips, neck surgery are now strongly indicated by the x-rays, at a minimum. There have also been excellent doctors who have treated patient C along his Odyssey. But it only takes a few poorly trained physicians to make a patient's medical file difficult for the next doctor to interpret. Patient Z's disease is complex, but shouldn't medical training provide analytical skills to address unusual collections of symptoms? Doctors are under such time pressure during their training that some of them use rote memorization to get by. Analytical skills are needed, but I wonder how many of the courses in medical school emphasize the need for the mindset of a detective who is not satisfied until all the pieces fit. In my observation, the more a doctor understands of a disease, the greater their concern to get it right and help the patient. Conversely, poorly trained doctors tend to show less compassion. One of the doctors who misdiagnosed Z with osteoarthritis said to him, "You'll just have to learn to live with the pain," as though his pain were not so severe. Patient Z was stoic and did not talk much about the pain of his diseases with the doctors. The well-trained doctors knew how much his condition must hurt, as much as anyone can empathize without experiencing the pain directly. I certainly could see his pain by watching him wince as he moved. One does not need to be an expert to see the damage to his body in X-ray images because the damage is so severe. Patient Z had many types of imaging done that consistently confirmed the rapid deterioration of his cartilage and connective tissue throughout his body. While this channel is dedicated to the issue of the doctor-patient relationship in the broadest sense, I want to focus on pain medication. This is an area where there is a great deal of controversy, precisely because it is impossible to measure pain. There are those who doubt that any pain is so severe that it requires the strongest medications known, opioids. An anti-opioid lobby has had an adverse impact on the doctor-patient relationship and really all medical treatment in the United States because of their belief that pain is exaggerated and their suspicion that pain patients just want drugs to feel good. Z's Odyssey documents a case that I feel could not be seen as an exaggeration of pain. Patient Z certainly is not an example of someone who wants to get high. Yet the fear of the anti-opioid lobby is that patients like Z will become addicted to their medication. They say that higher doses are a risk factor. The evidence for this is weak. The doctors told patient Z that he needed to taper, meaning they cut his dose. His dose was cut to the point that he contemplated suicide. I could never understand suicide until I saw how continual and disabling pain could make every moment of the day or night into misery. At that point, what is there to live for? As I began to investigate why patient Z was having such difficulty in getting the medication he needed, I learned about the role played by the DEA in persecuting Americans who need opioids and those who prescribe opioids for medical reasons. This is truly an example of law enforcement run amok. The DEA was formed to interdict heroin and cocaine smuggling. When that effort failed, the agency turned to a much easier target: America's pain physicians. America's doctors are being selectively targeted and prosecuted, as well as intimidated by the DEA, and more recently, even by state medical boards. The private healthcare system has gravely damaged the doctor-patient relationship. Insurance companies, institutional pressures to maximize profit, and pharmaceutical company representatives have all interposed themselves between the doctor and patient. As destructive as these policies have been, in pain medicine, there has been a direct intrusion of government into the doctor's office and the pharmacy. The medical community has been largely sidelined by government agencies such as the DEA, state law enforcement, and medical boards. Pain physicians can go to prison for prescribing at doses that federal authorities deem inappropriate. Pharmacists have been put out of business or even prosecuted merely for filling opioid prescriptions. Even those who treat addiction and provide maintenance medication for recovering opioid abusers have been shut down or prosecuted. Hundreds of news stories of such incidents have been reported in local media. However, the big newspapers and magazines, the major news media, do not publish an analysis of this nationwide trend that is adversely affecting millions of patients. Z's Odyssey documents the effects of this policy and gives some of the scientific, legal, and policy background. This channel is dedicated to finding a remedy for the injustice being committed against doctors and patients in America. All of this may sound improbable to an outsider to this problem. What reason could law enforcement have for prosecuting a well-meaning doctor? Consider a scenario in which a patient pretends to be in pain, and the pain physician believes the person. Then, if the disingenuous patient sells part of the prescription, the physician can be held responsible and face felony drug trafficking charges. In some cases, the DEA has assumed that patient deaths were caused by prescription opioids. Yet, elderly and sick patients may die of many causes, including natural causes. If they have opioids in their body at the time of death, it is often ruled opioid poisoning by the coroner. The doctor can then be held to account and face charges of manslaughter or even murder. One doctor put it this way to patient Z and myself. If patient Z were to step outside this clinic and be struck by a meteor, law enforcement would call it an overdose if he had opioids in his body at the time of death. I could easily be charged with manslaughter. There are many ways that a well-meaning and compassionate physician can end up on the wrong side of the DEA. In fact, merely prescribing over the limit set by state law as the standard of care is sufficient to warrant an investigation by a medical board. This can lead to further involvement of the DEA, including asset seizure and investigation of every prescription in an entire career in a search for any irregularity. A single abnormal prescription may be regarded by the criminal justice system as evidence of felony Medicare fraud. Many elderly doctors who've been treating patients for years, even decades, are now being arrested and incarcerated for the prescriptions they wrote decades ago. Sometimes a doctor will write a prescription while on vacation because of a patient's emergency. That prescription may fall outside the norms and be considered Medicare fraud. According to the DEA, pharmacists are also supposed to know if a prescription is legitimate or not. They are supposed to second-guess the doctors. Doctors are supposed to be able to discern if a patient is faking their pain. Failure to act in accord with the DEA's expectation can result in charges and long prison sentences, merely for trying to treat patients and provide them with medication. This is truly a matter of physicians' rights. I'm not denying that some doctors engage in criminal acts, but in case after case that I have read about, the reason for the investigation was misguided. In a number of cases, there has been coercion of witnesses, falsification of evidence, and prosecutorial misconduct. Certainly, the punishments are excessive when doctors are convicted of prescribing opioids improperly. Many sentences are more than 20 years. Ironically, a patient who sells medication, the one who actually commits a crime, but testifies against a doctor, will often receive a much shorter prison sentence, typically 5 to 10 years. Corporate executives of opioid companies have only been prosecuted in the case of the company Insys. The Sackler family, who owned Purdue Pharma, has been fined, but there have been no criminal indictments. Once the DEA has decided to pursue a doctor, the agency has a tremendous incentive to obtain a conviction, since 50% of the budget of the Division of Diversion Control is obtained from asset seizures by law. Any conviction will do. So if they cannot find evidence of manslaughter or drug trafficking charges, they scour the records to find any prescription that is not in good order and charge the doctor with Medicare fraud. As a result of the limits on dosing and increasing persecution of doctors and pharmacists, many have stopped writing prescriptions or selling opioid medications at all. State legislatures and state medical boards have supported this injustice since 2016, when a new set of guidelines were implemented by the Centers for Disease Control and Prevention, the CDC. The CDC process of arriving at the guidelines was secretive. It wasn't supposed to be, and it excluded the mainstream of American medicine during the discussion of what the guidelines should be. Even when the guideline was written, the agency did not follow established protocol, which is to post the document publicly for comment on the Federal Register. Perhaps the naive bureaucrats at the agency believed that this was only a recommendation. However, those who pushed through the dose limits, the anti-opioid lobby, had an agenda to prohibit many types of pain medication for most types of disease. The prohibition is extending to various anti-anxiety medications, and the anti-opioid lobby also believes that those are overprescribed. The belief is based on their idiosyncratic experiences and selective presentation of statistics. Several analyses of the CDC and National Institute for Drug Abuse (NIDA) databases show that the prescription opioid mortality was very small, even at the height of opioid prescribing. It was around 5% of the total in 2011. There is no public health or scientific justification for the dose limit that was implemented in these guidelines. We need to look at the science and options in healthcare management that have worked. The DEA has the power to implement guidelines once state laws have converted the CDC recommendation into a statute that sets a standard of care. The DEA officials who set policy for America's healthcare system have no medical or scientific training. They rely on a small group of physicians and public health officials who constitute the anti-opioid lobby. The great majority of America's doctors have not been consulted. They have been intimidated and in some cases arrested and incarcerated instead. I am, of course, describing the fallout from the opioid crisis that started in the late 1990s. This crisis has been widely misunderstood by politicians, the media, and the public. Even many doctors are confused by the complex set of events. One must practically devote oneself to investigative journalism to uncover the network of injustices and erroneous claims that an anti-opioid lobby has used to justify its actions. On this channel, I will try to break down the facts from published newspaper accounts, public databases, institutional reports, and scientific journal articles. I will invite experts to weigh in on the medical, legal, and social problems that have been created by current policies. A bird's eye view informs us that opioid prescribing increased dramatically from 1999 to 2011, and then fell just as dramatically during the next 10 years. This huge pendulum swing has caused untold human suffering. But how and why did this happen? The DEA has the most complete information. After all, that agency licenses every prescriber, sets annual opioid production quotas, and registers every shipment of opioids to a pharmacy on the ARCOS database. ARCOS stands for Automated Reports and Consolidated Ordering System. The astonishing fact is that the DEA did very little during the decade that the crisis grew. During that decade, corporations took advantage of government inaction and indeed corruption to send billions of opioid pills to rogue pharmacies known as pill mills. The corporations were able to send billions of opioid pills to small pharmacies in rural Appalachia and southern Florida, which became pill mill centers for illegal distribution. These are merely examples that are very well known. This happened all over the United States. While some DEA officials and agents made a good faith effort to put a stop to corporate diversion, they were thwarted by the upper administration, the Department of Justice, and even the U.S. Congress. The DEA has prosecuted small-town doctors for opioid prescribing for many years. That occurred throughout this period as well, despite a supposed agreement with the medical community that was brokered at the University of Wisconsin in 2002. The DEA broke the agreement and began prosecuting doctors again in 2003. Each time a pain physician's practice was closed, there were hundreds or even thousands of patients who suddenly lacked care. Many of them were sick and elderly people who were destabilized by withdrawal. When they did not get their medication, they had nowhere to go. The DEA turns a blind eye to this suffering. After all, they seize the doctor's assets, and that helps their budget. They get bonuses for convictions of pain physicians. Indeed, when the DEA administration refused to investigate the large opioid manufacturing corporations, some of them took advantage and began selling opioids on the internet to anyone who made an order. Later, they switched to pill mills, and for many years, they were able to ship millions of pills to West Virginia, and several counties in Florida. Many rank-and-file DEA agents were disturbed, but they were unable to take any action. This aspect of the crisis has been described well in Alex Gibney's documentary, The Crime of the Century. The rapid increase in prescribing without any guardrails or any type of diversion controls resulted in abuse. Indeed, for nearly a decade, prescription opioid drugs became a significant contributor to opioid overdose death. The newspaper stories and political speeches that suggest that opioid prescribing sparked a drug overdose crisis are badly mistaken. There has been an overdose crisis in the United States since the 1970s. The U.S. has consistently had the highest rates of drug use and overdose of any country in the Western world. Certainly, the prescriptions written to those who had real pain were not in any way connected to the abuse or the drug overdose crisis. However, media reports have muddied the waters and presented physicians' prescribing as the cause of the crisis. This has continued up to the present, even after prescribing had been reduced to the pre-2000 level. The media always calls on the same experts, and these individuals are well-paid consultants and expert witnesses from the anti-opioid lobby who played a major role in the current draconian limits on prescribing. Pain patients have been hurt the most. Tens of millions of people who have chronic pain that interferes with their daily ability to work or take care of a family have been cut off. Almost 8 million people with serious diseases that cause deterioration of joints, tissues, bones, have been limited to doses that are often much too low for the intractable pain of their disease. People who have suffered car accidents, lightning strikes, industrial accidents, and wounds from the battlefield have been either abandoned or tapered to a dose so low that they could not stand the pain. The suicide rate among America's veterans is astonishingly high and grew in recent years, particularly after their access to opioid medication was diminished. Pain is a leading cause of suicide. Often society does not even know, since pain is a taboo subject. Succumbing to pain is considered a sign of weakness in America. Some even consider it indolence. It is hard to imagine if you yourself have never experienced the kind of debilitating pain that is possible. The pressure of insurance authorizations and the institutional pressure to see as many patients as possible have not served patients well. Aside from the issue of obtaining a diagnosis, the fragmentation of healthcare into specialized offices and clinics keeps a patient busy just to make appointments if they have a serious illness. Z sees a primary care physician, a rheumatologist, a lymphedema clinic, a foot and ankle specialist, a dermatologist, an orthopedic surgeon, an endocrinologist, and a pain physician, all at different locations. The list changes with time, and Z has had 4 different rheumatologists, either because of a doctor leaving the area or because of a rheumatologist who refused to accept the NIH diagnosis of ankylosing spondylitis. Ensuring that these doctors have current information from each other takes a great deal of effort on a patient's part. Of all these various physicians, the pain specialist has been the most difficult for patient Z. I do not have time to recount Z's Odyssey on this webcast, but I can say that patient Z has experienced extreme tapers and finally abandonment. Not because he did anything wrong or even out of the ordinary, but merely because his pain was so severe that he became a legacy patient. He needed a high dose of opioids in order to be at all comfortable. Patient Z was at the end of a 6-year odyssey in various pain clinics and palliative care when he found a pain institute and clinic in a city about 100 miles away from his home. It was there that Dr. P first recommended buprenorphine. It was a recommendation, but we could suspect that Dr. P would not want to prescribe morphine or oxycodone at the levels that patient Z needed either. Dr. P assured us that buprenorphine is pain medication. In fact, he had done clinical studies in the Research Institute, and he showed us the data. I had read enough of the news and views from pain advocacy websites to understand that most patients think of buprenorphine only as addiction medicine. But this is not true of pure buprenorphine. The addiction medicine is buprenorphine combined with the strong antidote naloxone. This combination was patented as Suboxone. The patent is expired, and there are generic forms now, such as Zubsolv. Suboxone is not appropriate pain medication. Naloxone will compete with the pain medication and reverse its effect. Even though the bioavailability of naloxone is supposed to be significantly less than buprenorphine when taken under the tongue or sublingually, the literature data show that naloxone is 1/3 as bioavailable. Some of it gets into the bloodstream. The reason that Suboxone is addiction medicine is that naloxone discourages injection. From media stories and reports of high overdose mortality, many people may have the impression that opioids are intrinsically unsafe. In fact, when used as directed, opioids are as safe as other common painkillers. The organ toxicity of opioids is much lower than aspirin and the non-steroidal inflammatory drugs, so-called NSAIDs, like ibuprofen and naproxen. These common drugs do have organ toxicity. The one fatal risk factor for opioids is respiratory depression. If the dose of opioids increases too rapidly, the pain receptors in the brainstem can react by ceasing to send the neurotransmitters needed to initiate a new breath. A person who takes opioids as directed at constant dose, or at a gradually increasing dose during the initial phase known as titrating to the pain, is not in great danger. A person who has a great number of pain receptors because they actually have pain is also not in great danger. However, a person who's completely healthy who takes opioids, drinks alcohol, takes sedatives, there are negative synergistic interactions that can lead to respiratory depression. Sedatives can be used at low dose, but the risk is sufficient with morphine and similar drugs that it is not advisable. On the other hand, when people abuse opioids, they most often inject them. The dose is not well controlled unless a person is both experienced and quite careful. In the era of fentanyl, it is almost impossible to predict the dose because fentanyl can be present in such a small amount and can still be lethal. More people are combining drugs. Cocaine, methamphetamine, psychostimulants, and many other types of drugs are now found in the body on autopsy. A recent report found the average number of drugs present at the time of death was 6. The overdose mortality statistics are therefore very difficult to interpret. However, the strength and prevalence of fentanyl makes it a candidate for the most toxic of all the drugs. None of this has anything to do with doctors prescribing. Most pain physicians have been careful and kept the dose relatively low. Despite these facts, physicians are being discouraged from prescribing opioid medications. I mean that they fear prosecution and they make the practical decision to send their patients to a pain clinic. As Patient Z discovered, the pain clinics are simply opioid control centers. Now, state medical boards have joined the policing effort. Rather than advocating for doctors' rights, they've become the first line of prosecution. Patients never had any advocates, but now they are without any significant rights. Patient abandonment is illegal, yet hundreds of thousands of pain patients have been abandoned. No one dares file a lawsuit. The climate is such that pain patients are more suspect than any other type of patient. The only instances where there has been any justice is when the pain became so bad that a patient committed suicide and the family filed suit. The case of Brent Sloan was written up in the New York Times by Milovitz. Mr. Sloan had terrible injuries from an automobile accident. Initially, the doctors did not think he would survive. He did survive, and for years lived with his family, although bound to a wheelchair and confronting intractable pain on a daily basis. He had received opioid medications that had mitigated the pain to the point where he could live a meaningful life. Then, suddenly, the clinic terminated his medication. He begged with them and searched for another clinic to no avail. Shortly thereafter, he committed suicide. His family sued for malpractice and won a multi-million-dollar settlement. However, most suicides are not subject to lawsuits, and there is often no justice for the abandoned patient who simply could not continue living in pain and refused to self-medicate with illegal drugs. The reason for telling Patient Z's story is that his experience with buprenorphine was good. To be honest, Patient Z would have not chosen buprenorphine if he had not been abandoned. But he followed Dr. P's advice. Patient Z gradually replaced 100 morphine milligram equivalents, or MME, of morphine and oxycodone with the buccal form known as Belbuca. When he reached the maximum dose of Belbuca and still felt a great deal of pain, he did some research and learned that it is possible to prescribe the sublingual form of pure buprenorphine, but it must be done off-label. To prescribe off-label means that the drug is FDA approved for one disease, but it is being used for another. In this case, it's FDA approved as addiction medicine and is being used as pain medicine. The assumption is that the drug is safe because of the original FDA approval. Subutex is FDA approved as addiction medicine, but not as pain medicine. It is pure buprenorphine, and it is perfectly appropriate as pain medication. It is odd that the FDA has not approved Subutex for pain. But fortunately, Dr. P agreed to switch Patient Z to Subutex to increase the dose until Patient Z was comfortable. Patient Z reports he is getting the same pain relief he obtained on more than 180 morphine milligram equivalents of morphine and oxycodone using Subutex. The drug is considered safe, and the Pain Institute is not in any danger of being scrutinized by the DEA, as long as they follow normal procedures. Patient Z must provide a urine sample at regular intervals to show he is not abusing the medication or any medication. Some patients find this humiliating, but Patient Z has taken a pragmatic view. Since his pain is relatively well controlled today, he feels that the trade-off of a urine sample is acceptable. I use the words relatively comfortable because I do not believe that Patient Z is ever truly comfortable given how severe his disease is. But at least today the pain is bearable. I personally think that the ability a patient has to control the pain is perhaps the most important psychologically. There is nothing worse than feeling uncontrolled pain. Z's Odyssey is a personal account. It mainly describes the experiences of a patient who has passed along through different pain clinics, palliative care, and finally arrived at a pain research institute. It describes his disease and the levels of medication that helped him. It is a case history. Like all individual accounts, it is anecdotal. However, many such anecdotal accounts can be found in the medical literature. These have a place as teaching examples. I sincerely believe that Patient Z's Odyssey is a teaching example. The solution he found and the way he found it could help other pain patients who've been abandoned or who are under-medicated. I am not suggesting that all patients should switch to buprenorphine. I am merely pointing out that it is a possibility, and this is important particularly in a time of crisis. The crisis I'm concerned with is the crisis of undertreated pain. The perverse incentives of the DEA and state governments have driven doctors away from pain medicine. Patients have been abandoned or refused treatment in large numbers. When I read about patient suicides, I wonder whether anyone was there to tell those patients that there was a pain medication called buprenorphine that they could take that would relieve their pain. I think the answer is probably no. The FDA has only approved high-dose buprenorphine as addiction medicine, but doctors are prescribing it off-label for pain, and it works. The stigma against the use of buprenorphine is enormous. Doctors fear it because they see it as addiction medicine, and many doctors do not want to treat opioid use disorder. Patients fear it because they too believe it is merely an addiction medicine, and that anyone who suggests that they take buprenorphine is suggesting that they are addicted. Patient Z would rather die than accept a diagnosis of opioid use disorder. Indeed, Patient Z has been in such pain that I know he has looked into suicide. No one has suggested that Patient Z was addicted, and indeed, the Pain Institute has been very clear that they see Patient Z as an example of an intractable pain patient. I hope to expand this discussion to include other patients and doctors who've been mistreated by the current oppressive system of opioid regulation in the United States. We are living in a time when the war on drugs is being fought in doctors' offices. Thank you for listening.